Okay, so we talked about 4 of the 5 things. We were talking about all the different things that affect labor. So the first thing we talked about was the passageway. So what did we talk about with the passageway? Okay, the different types of pelvis, right? So what are the 2 types that are okay for us to deliver? Gynecoid and anthropoid. So the gynecoid and anthropoid. Okay. All right. So the types of pelvis. All right. What else do we talk about with passageway? Anything else that you can think of? What do we talk about with? Okay. True and false. It can be mixed. Mixed types are most common. Yeah, we talked about the true pelvis and the false pelvis. We talked about the brims. You know how the true pelvis is actually the bony part, right? How they sink down.
Are the mixed types more common or the gynecoid?
Mixed types are more common than gynecoid. I mean, of the 4, if you're looking at pure types, gynecoid is the most common pure type that people mostly have mixed types. Okay, so remember that the false pelvis is up here, floating above the brim. The true pelvis means that it's settled down into the brim, right? Okay, so what did we talk about? What happens as we go through pregnancy to this pelvis? What does it do?
It's movable.
That hormone, that fancy hormone called relaxin, right? Is secreted and it causes the joints, the tendons, the ligaments to relax. And so it spreads apart, and that might cause some discomfort to the woman as everything's spreading and changing.
And is that what actually makes the coccyx
movable? Yes. Makes the coccyx movable. Okay? Alright, so we talked about the passenger, right? So the first thing we talked about is the size of his little noggin, right? The size of his head, that he has sutures and fontanelles, and they do what? To make sure that he can get through here.
Overlap.
So they mold, they overlap to get through this pelvis, right? So the 2 fontanelles that are the most important ones to remember are the anterior, right, and posterior. So what does the anterior look like?
Diamond.
And when does it close?
12 to 18 months.
12 to 18 months. And it's a great little tool, assessment tool, that little fontanelle, because it can tell us a lot of things, right? It should be flat, but if it's bulging, it tells us what?
intracranial
Too much pressure, too much intracranial pressure, and if it's sunken, dehydration. Okay. And then the posterior fontanelle, which is triangle shaped, and it closes 6 to 8 weeks. Right, and that's important because we lay those babies on the back of their head, so that's a good thing. Okay. One thing I didn't say yesterday though, is it normal to see a slight pulsation in that fontanelle? Yeah, it is. So don't panic if you ever see that. Okay, is molding going to last forever?
No, that one.
No, the anterior. Okay, doesn't last forever. All right, we talked about the attitude of the baby. What is the attitude? The relationship of the fetal parts to one another. What is the most common attitude? General flexion. So we want him to be all bunched up, right, in the fetal position, like chin to chest, knees flexed at the abdomen, right? So he looks like a little ball. So general flexion is the most common attitude. Okay. All right. Now we talked about fetal lie. Okay. So how do I know the fetal lie? What is this?
It's in relation to the mother's
Right, the relationship long axis to long axis, right? So this lie is longitudinal versus this lie, which is transverse. Can you deliver this?
No.
You can't vaginally deliver a transverse lie, right? And remember T, it's T shaped, transverse. So longitudinal versus transverse lie. Okay. Right? The next thing we talked about was his presentation. So how is he presenting? Okay, so there's 3 different types. So if he's like this, he's cephalic, so head down. If he's like this, he's breech. And if he's like this, he's a shoulder, and they look like they're gonna break their little necks. What's the most common? Cephalic, which is a good thing, right? Okay. And you may see in your book, I don't know if I mentioned this yesterday, but there's another term you may hear people say, vertex. So cephalic or vertex, those are kind of interchangeable words. So we have cephalic, we have breech, and we have shoulder. Okay. Can you deliver a shoulder?
No.
No. Can't. Okay. All right, and then we talked about, when we were looking at presentation, we also talked about engagement. And remember I said that when you become engaged, it's kind of, you're locked in, right? So when you're engaged, that means the presenting part, bless you, has settled down into the true pelvis. So it's locked in. So he is, at that point, whatever is presenting is how he's going to present. There's nothing you can do about that. Correct? Okay? So we want, when he settles down into, when he engages, we want it to be cephalic. That's our goal, to be cephalic. If he does not flip before he engages and he has in his breech, okay, have him sitting in here yesterday like this, okay, he's breached, then can you deliver that? You can. Is it a good idea? No, because they'll have a lot of hip issues. Okay. But if you are, say you're the emergency room nurse, and I always tell people, just because you don't love OB, then you say, I am never going into OB, and you are the emergency room nurse, I'm going to be critical care. Well, guess what, guys? A lot of babies are delivered in the emergency room. So those of you who are going to be an ER nurse still have to know some of this stuff, right?
We delivered one of our babies last night in the ER. It was crazy. The girl said she did it when she was pregnant.
Oh, I love that.
It was like, it was great.
Good experience for you before class today.
Here. No. If you've ever been pregnant, you know, it's a state of mind. They don't want to
Denial.
They don't want to think about that. You know. But anyway, okay, so but if you're the emergency room nurse and you go in to do your assessment on this patient and you see that, right? Remember how we talked about that yesterday? That's a footling breach.
You're gonna have
right?
a
At that
gymnast
point,
on
we're
your
kind of
hand.
stuck, right? He's going to have to come. But again, the problem is that his hips can have a lot of damage. So you have to be real careful. Okay. Let's support. Okay. All right. So we had engagement, and then we had station. Remember, we talked about station. Where is 0 station? The ischial spines, and I passed the pelvis around so everybody can see where those ischial spines are. So what station means is that the presenting part, whatever it is, whether it's the bottom, the head, whatever, has settled down, has engaged, and it is at 0 station. Okay, so it's now at 0 station. Now, what is below 0 station? Positive, because remember it's positive to be born, and +4 is on the floor, right? So So once you get to that point, the baby is delivered. So the negative numbers is reversed from fundal height. And a lot of people get those backwards. When we're checking fundal height postpartum, those numbers are reversed from what? So the positive numbers are up versus down below. Does everybody understand that? So just keep in mind it's positive to be born, so the positive numbers are below the zero. Okay. Let's see what else did we talk about yesterday. Oh, the position of the baby. And remember I said that I'm not going to give you a picture and expect you to tell me what position it is, but I do want you to know what those three letters mean. Okay, so it's either R or L, and what does that stand for?
Right or left.
Right or left. The middle letter is going to be either O or
S.
S,
M.
M,
Or SC.
or SC. Right, and what does that stand for? Occiput, sacrum, mentum, or scapula, right? We're going to go with this. Okay, let's do a fancy word. Okay, and then what does the last letter stand for?
A.
A or
P or T.
A or P or T. So what is that telling me?
Anterior, posterior,
or
transverse.
transverse. Alright? What do we want him to be in?
ROA.
ROA or
LOA.
LOA. Right, we want occiput anterior. That's our biggest, that's what we really want. Head facing front.
So in this particular one, occiput for us is cephalic.
Right.
Doesn't matter.
Head.
Although this is occiput back here.
Right.
We're talking occiput is anything cephalic.
Anything's cephalic.
Okay.
Unless we're talking about the chin or the face.
Okay.
Right, remember I said that if it's a face delivery, if it's a mentum, a chin, and it's a face delivery, those little faces just look so pitiful. They're torn up, they're bruised, they're scarred, all of it. It's just pitiful. Okay. Alright, then we talked about powers or forces, or what's called as forces, and we have primary and secondary, right? So what are primary forces? Can we control them? No, it's involuntary, it's going to start no matter what, right? Okay. So contractions, so let's talk a second about the contractions. So when we're looking at a contraction, right, what is the duration of the contraction?
Beginning to end of the
beginning
same.
of the contraction to the end of the same contraction, right? So that's the dip. That's the duration. What's the I? Intensity. So what does that tell me?
The strength of the contraction at the peak.
Okay. And then what is the F? Frequency. So what is frequency?
Beginning to beginning of next contraction.
The beginning of the contraction to the
Beginning of
the next contraction. Okay. We have secondary forces or secondary powers. Can we control that?
Yes.
Yes, that is voluntary bearing down. That is the voluntary bearing down of the woman. Okay. So as we are bearing down, what occurs to the cervix? There's two things it does.
Thins and
It
stretches.
dilates and it effaces. So when we efface, what does that mean?
Thinning.
Okay. And how it's thinning and how is 0 to
100.
100%. And then dilation is
0 to 10.
10 centimeters. How does that work? How does it do that? What is he doing? Okay. Remember we talked about Play-Doh? Or Dodo? Okay. So he's pushing down. So as he is pushing down, remember it's like our fist. So we're pushing and we're pushing and we're pushing, and it's spreading the dough up, right? It's thinning it in the middle and it's spreading those sides up, just like that. And you felt that hopefully yesterday in the box. You know, by 10, by the time we got to 10, it was harder, wasn't it, to get your hand up in there and feel, because it had drawn up. And remember, they're like pacemaker points. We have to start at the top of the uterus and work our way down. And I said later on we're going to talk about dystocia, which is abnormal labor, where the pacemaker point actually starts in the middle, and that's not good. We've got to work our way down to push it out, okay? So it's like a pacemaker. All right. When do we start pushing?
10 seconds.
Right. And?
9%.
Yeah. Should we start before the input? No. Bad. Because what will it do? It starts to swell, and they're going to be pushing for hours, and then all of a sudden they're going to say, "Oh, you got to have a C-section." And that poor woman that has been traumatized for 10 hours now all of a sudden has no surgery. Okay. How do you think the recovery would be for that person?
Very hard.
A lot harder, right, than if she went in and had the section to begin with, or worked her way slowly up to deliver that baby, because she's taking a surgical procedure on top of having spent all these hours pushing. So it's a lot harder for those women to recover because you've got a double whammy now. Okay? The last thing we talked about, well, the position, and position kind of went along with the ROA and all that. The last thing we didn't really hit much on was the psyche of the patient. You're going to see different types of mental status during labor. You're going to see some people who are excited and they're ready and they go in there and it's like a challenge. I'm going to get through this. I'm going to deliver this baby. And then you're going to see some, like the one in the emergency room, who swears they didn't even know they were pregnant. Okay? You're going to have different age groups. You're going to have the really young who have no clue what they're doing. And you're going to have some who this is their 6th kid and this is just like nothing to them, and they can push that child out and keep going and no problem. Okay, have you seen that?
Yeah.
Have you seen some of those situations yet? If you haven't yet, really pay attention to their mental status, their mental health, because it can affect them during labor. If they're excited and they're ready to deliver this baby and they were planning it and it's just so exciting, they're going to get through the labor process a lot easier than someone who was not excited, who this was not planned, or they're young and they have no clue. Maybe they have no support. Maybe they don't have a support person. You will see a really big age range. I was telling, I think a couple people were in the front yesterday. This weekend, one of our hospitalists that used to work with us, she's working in Wilmington now, and she had a child referred to her for high blood pressure, a 10-year-old. The 10-year-old had high blood pressure. And come to find out, she was pregnant. The 10-year-old was pregnant, and it was a rape situation. She'd been raped by the grandmother's boyfriend. But a 10-year-old, their pelvis isn't even finished developing yet. So, you're going to see those, they don't even know what's going on, with their bodies. They can't identify that. So you see those very, very, very young. And then you may see some older mothers who thought they were done, and it was a surprise. And they, even though they may have 4 of their kids, this was not something that they were expecting at this point in their life. So you're going to have a lot of age range in OB. All right. So we good on this? Think we got a handle on all this? Let's talk about how we know that labor is getting ready to start. All right. There's a lot of theories about labor. Nobody really truly knows the one thing that's going to trigger it. There's a lot of theories out there. You do know, and remember I asked you when we were talking about what you learned in Antepartum, you mentioned those 4 hormones. Remember we talked about those 4 hormones? One of those hormones was progesterone. Remember that? Okay. We do know that progesterone is important during pregnancy because what does it do? Do you remember what progesterone, what the, it keeps you pregnant by the how? It relaxes the smooth muscle, so it relaxes the uterus. It keeps it from contracting, okay? So progesterone relaxes the smooth muscle. We do know that right before, right at term, okay, right at term, that progesterone level drops dramatically. So if progesterone is responsible for relaxing the smooth muscle and keeping it chilled out, and then all of a sudden it drops out the bottom, what's going to happen to that uterus, that muscle? Those muscles are going to start contracting. Those muscles are going to start contracting. So that is one theory about what triggers labor to occur. Okay. Prostaglandins are also produced and released. Prostaglandins are also produced and released, and those prostaglandins will stimulate contractions of the uterus. Prostaglandins are used in inductions as well. How many of you got to see an induction yet? Okay, you were induced. Okay, was anybody induced in here? Oh, yeah. Okay. So what did they use? Pitocin. Okay, Pitocin. Did anybody use one of the vaginal suppositories?
Oh, yes.
Oh, yeah, those things, yeah. And what they do is they kind of melt, okay, and that melting causes, it stimulates, stimulates that uterus to start contracting.
Is that the same stuff that they give you whenever you get an IUD?
It should, you would look contracted by the I have an IUD and I can do it.
I know that some women have like low levels of progesterone. What do you keep the pregnancy viable?
That's a very good question. And a lot of those women who have low progesterone levels are monitored very closely because they can go into preterm labor very easily. Yeah, during pregnancy. Yeah. They have to really, because you will lose the baby very easily to do that because it'll stimulate that uterus to contract. Okay, the other thing that we know is that there's something called Corticotropin-Releasing Hormone. Have you ever heard of that before? CRH, Corticotropin-Releasing Hormone. Okay, Corticotropin-Releasing Hormone. That hormone increases sharply right before term. So that may also be a trigger. Corticotropin-releasing hormone synthesizes, what does the word synthesize mean?
Produces.
Uses it, it makes it, takes what there's there and it makes it usable, right? Synthesizes those prostaglandins that were released. So they work hand in hand. We have to have both of those substances in order for pregnancy or labor to begin. So there's a lot of different theories out there. This picture shows you estrogen and oxytocin as well. Oxytocin, of course, causes the uterus to contract. And you're going to talk about oxytocin or pitocin during postpartum a lot too, because they give you shots of oxytocin after birth to make that uterus do what? If it's not contracting, you want it to contract to prevent what from happening? Hemorrhaging. So we do know that oxytocin is released, and of course that's from the brain, and then estrogen from the ovaries causes that oxytocin to be released. So there's a lot of different things that can occur. Okay, a lot of different things that can occur. All right, now let's talk about the process of labor. Okay, so you're just having having herself a good old time being pregnant, and then all of a sudden, things change dramatically, okay? That baby that was once up here, you know, and I don't know if you've talked about this in Antepartum, but, you know, one of the ways that you know you're pregnant is because you pee all the time, right? And then in the second trimester, what happens to that baby? He rise up because the uterus is growing, right? So he's coming up. Well, all of a sudden now, he drops, and it happens about 2 weeks before term, and it's a process called lightening. So he is lightening down. He's working his way down because now what have we got to do? He's got to get engaged, right? So he's lightening. He's drifting back down. And so once again, we are now having to go to the bathroom all the time again because the pressure of the presenting part is putting pressure on that bladder. Okay, so now that we have to pee more, what are we doing up here? Which is a good thing.
And breathe.
We can breathe again, right? So we can breathe again, but we're having to pee more. Okay, so lightning can be a good thing in some respects because of that fact. All right. A lot of women complain of low backache. Now that is different than back labor. You mentioned preterm labor. We talked about preterm labor yesterday, and one of the signs of preterm labor is back labor, or that radiating pain to the back, right? Yes.
Mm-hmm.
Okay. So this is different. This is a backache. Now, this backache could be because he is turned in the wrong position. Remember I said that we want him in an occiput anterior position, right?
Yeah.
Yep. Okay. If he is in a posterior position, if that third letter is a P, okay, so if he is R-O-P or R or L-O-P or one of those positions will cause back labor, okay, true back labor. And the way to get around that is to get the mother up on all fours on the bed, get her up on all fours, so that the stomach is dragging down, and see if that baby will flip itself. That'll help release it.
This may be a dumb question, but is there any way the nurse could like move the positioning of the I mean, you know, because you're kind of feeling the baby, so.
Once the baby, we're going to talk about versions too. I'm not a big fan of versions. They offered it to me, and I said no, because it's very risky. But once the baby is engaged, you cannot turn the baby, okay? Versions, which I'll just mention this now and we'll talk about it again, but versions, you have to complete a version, which is manually reaching up inside them and trying to lift that baby around. It's very painful. Has to occur before the baby is engaged. So it occurs in that 2 weeks before term, before that baby starts lightening down. Okay. But it's very risky too.
So like
Very
in these emergencies in the labor, it's all BS.
Yeah,
Just out of curiosity.
TVs, on TV, it's like, ooh, yeah.
Well, just a little bit.
Okay, so you can turn the mother side to side, get her up on all fours, do things like that to try to get the baby to turn. But other than that, you don't want to press down on the stomach and all that kind of stuff because you're going to risk rupturing that uterus, and we don't want that to happen. So, okay. So we talked about low backache. Bloody show. Everybody, have you heard that term before? Show. Show is blood-tinged mucus. Blood-tinged mucus. It's that cervical plug, that operculum. This Walker talked about it in operculum.
Not that word. Just the mucus plug.
Well, the mucus plug, the correct term for a mucus plug is operculum. Okay? And the operculum, what's its purpose?
Keep bacteria out.
To keep bacteria out, right, so that we don't get an infection during pregnancy, right? So at term, when labor starts, that mucus plug, that operculum, comes out, and it looks like, for lack of a better term, and it looks like slimes. What it looks like somebody sneezed big time. You know how kids sneeze when they're real little, and then it's all over their face and their hand. Y'all have seen that before. I love these babies. And so they sneeze, and they got it all over themselves. That's what it looks like. And it's like sticky, like slimy. It's just special. But it's blood tinged. Okay, because all those little capillaries now are starting to also rupture with the pressure of that baby coming down. So it may be a little bloody, nothing to be extremely upset about. Once that operculum comes out, though, what does that mean for the woman?
Increase infection risk.
She's in increased risk for infection, right? So once that mucus plug comes out, she needs to be taught that she has to be very aware of her body, checking her temperature, making sure, because sometimes that mucus plug will come out several days before actual labor begins. So you've got all this time now for all those nice little bugs to crawl up inside and get there's a common infection called chorioamnionitis. Okay, what does chorioamnion sound like?
Infection.
Chorion and amnion. Remember those two things? The two sides of the placenta. We have that chorion and amnion. So it's the placenta. Okay. So here's the two layers, right? The chorion and the amnion. So it's an infection of the placental lining. Okay. An infection of the placental lining. Okay. This is one of my favorite tools because I like to show how the layers come together. All that fun stuff. Make the sack.
That would have been my test.
Probably. Yeah. How they come together and then they make the sack. So chorioamnionitis is an infection of the placental lining. Okay, let me pass around now. All right. All right. Okay. Cervical ripening. What does it mean when it's ripe? It's like a melon. We're going to the grocery store and thump the melons, right? Starting to get ready, so it's softening. The cervix is softening because what's it got to do?
Open
It's
up.
got to stretch and get thinner, right? Stretch and get thinner. So cervical ripening occurs. Some women say that they have a loss of weight. Now, it's not significant. It's not like, yay, I've lost weight. And you wouldn't even notice if you aren't standing on the scale. And I don't know why in the world you would think, oh, I need to stand on the scale. I don't know why you would think that, but there is a very slight loss of weight. Okay? A burst of energy. What do people call that burst of energy? Nesting. And it really does occur. It really does occur. And I think it is nature's way of getting us ready for this, to protect this new being from the dinosaurs that are going to come and eat us. Okay, so the burst of energy, Braxton Hicks contractions. Okay, now during Braxton Hicks contractions during pregnancy are supposed to be painless. They're not comfortable. I'm not saying that they're the greatest things on the planet, but they're not painful like labor pains. Okay, what were those Braxton Hicks? We mentioned this yesterday too when we were talking about what you learned in Antepartum.
Practice contractions.
They're just contractions that are getting that uterus ready to be stretched all the way up to here. Remember that an actual uterus is about the size of an almond. It is tiny. It is tiny. You can't feel, I don't know did y'all talk about this? I don't know if you talked about this or not, but you cannot feel the uterus in a non-pregnant woman. It's settled down into the pelvis, and you can't feel it. So you have to do those Braxton Hicks contractions so that it will stretch all the way up to the diaphragm. So you got to go from this to this. Okay? Now, the Braxton Hicks contractions that were painless before are now getting worse. Okay, now they're increasingly uncomfortable. And then the last thing that I wanted to bring up is a rupture of membranes. With that rupture of membranes, 90%, bless you, 90% of women will begin labor within 24 hours. If they don't, they may induce them, depending on how risky the pregnancy is. Remember too that the sac, the amniotic sac that's filled with water, not only did our mucus plug protect that pregnancy, but the amniotic sac did too. And so now all that water's rushed out, and now that baby's just freely laying inside the uterus, right? So it's just sitting there ready for something that could occur. Something can happen. So you've got to be really careful letting a woman, after their membranes rupture, just stay at home. You got to really keep an eye on it, making sure that that baby is okay. All right. All right. Everybody good so far? All right. So there's a nice little chart in your book on the differences between true labor and false labor. I want to tell you the main difference. I want you to find it on that chart, and I want you to star it, because this is the biggest difference in how you know true labor versus false labor. There is change in the cervix with true labor. There's change in the cervix with true labor. It's towards the bottom, I think, of that little chart. Okay. True labor is when the cervix begins to efface and the cervix begins to dilate. A lot of the other symptoms are the same. They have the contractions, they have that discomfort. But the way that you know that, yes, you are in labor is that the cervix is changing. Does that make sense? Because all those things that we just talked about are causing that to occur. All right. You should have seen on Blackboard, there was a chart that had the 4 stages of labor. And I like charts. Kind of looks like this, but it doesn't have all the stuff written in it. It says stages, duration, evidence, assessment, and others' behavior. If you didn't print that out, just take a blank sheet of paper and kind of turn it landscape. Okay. And I want you to make 5 columns. Make 5 columns on your paper. The first column I want you to put at the top stages. The second column, duration. The third column, evidence. The next column, fourth column, assessment. And then the last column, mother's behavior. We'll write it on the board too as we go along. I think that the columns work this year. Alright. Now, there are, the book says there's 4 stages of labor. The 4th stage is after the delivery has occurred. So we'll bring that up in just a minute. Right now I want us to talk about the 3 stages. Okay, so the first stage. So we have determined now that yes, this is true labor because we can tell that the uterus, the cervix is changing, right? That it's effacing and dilating. We can tell that something is occurring. So we know that this woman is in true labor. So the first stage has 3 phases. All right, does everybody hear that? The first stage has 3 phases. It's the only stage that is broken down further. Okay? So the first stage has the latent phase. Okay. The active phase. And the transition phase. Alright. The latent phase, we're going to talk about it in each of these little things. Okay, the latent phase lasts from anywhere from 0 to 3 centimeters of dilation. 0 to 3 centimeters of dilation. And it usually takes at least 6 to 8 hours. The doctor's going to say stay home. This is not when they need to come to the hospital yet. Okay, you can labor in that early phase at home. It's more comfortable anyway. A lot of women don't even realize that they've gotten to 3 centimeters until their chest. I know I didn't, and it was my first pregnancy, and I wasn't even supposed to be dilating because then it was going to be a section because it was breech. And I go in just for a regular checkup, and I didn't go back home. You know, she sent me right up to the hospital because I had dilated to 30. It's uncomfortable. Remember that pelvis that's stretching and moving and changing? So it's uncomfortable, so you know that something's going on. You may have, the evidence that you're there, you may have mild to moderate contractions. If we're looking at the dip, the duration and frequency, the dip is, or the D is that they last 20 to 40 seconds in duration. And that the frequency, the F, is that they're 3 to 30 minutes apart. I don't have an intensity for you, just about a mild to moderate, that's right. Okay. If for some reason they're at the hospital, okay, maybe they came in and the doctor said just let them stay for some reason. If they're at the hospital, you're not going in to do any kind of assessment but every hour or so. It's more, you're just checking to make sure that they're okay. Now, at this point, the mother is smiling, she's talkative, she's doing her makeup, and she's thinking to herself, Lord, if this is labor, I can do this all day long. I'm going to have 20 children. This is nothing. I don't know what all these people were talking about. This is nothing. I can do this.
When I was in labor, I woke up, first I was 2 weeks overdue, and I took a bath, I was sitting on my yoga ball on Facebook, and my parents tried to work out, my mom was like, you're not in labor, you're on Facebook, you're working out, this is not labor, and I was like, okay, 2 weeks overdue, and I woke up at 3.
Yeah, obviously. Okay. So you know when they come in, they're so, you know when a woman comes in and they're in this phase versus like this transition phase, because at this phase they've done their hair and they've got perfect makeup on because they're going to take all these pictures, and they've got a professional photographer coming and all this stuff, and they have all their suitcases and.
Is it possible for someone to dilate early and just stay that way for like an extended period of time?
Yes, but it's risky. It's risky. Yeah. Because the further you dilate, more can get up in there, and the baby can drop down too much. Okay. So now, if she's at the hospital at this point, generally at this point, the membranes have not ruptured. Okay, so typically you still have the amniotic fluid still in there. You can allow her to walk, all right? So she can get up and she can walk around. It's great. She can bounce on the yoga ball or whatever. Okay, but you can only let them walk. This is very important. I want everybody to hear this. You only should let them ambulate if either the membranes haven't ruptured, or if the membranes have ruptured, you are sure that that baby is engaged, that it's locked in place. Because if it's not engaged, if the membranes rupture and that baby is not engaged, then that umbilical cord may drop below the baby, and you may end up with a prolapsed cord, and that is an emergency. Okay? So let's say that Miss Sunny Sunshine here is walking in the hall, bebopping around, and all of a sudden she stops and this puddle of fluid is between her legs on the floor. What are you going to do? You're going to say, you need to go back to your room and lay down so I can check you. Okay? I need to check you. If that baby is at that zero station, if he's locked in place, you're good. She can walk some more. She can keep walking some more. But if that baby is still floating, if it's still up, bless you, above zero station, then she stays in that bed. Okay, does everybody hear that? Very important, because you do not want that cord to dip down below. Because what's going to happen is if that cord drops down and then the baby decides, oh, I'm going to become engaged now, it's going to clamp off that umbilical cord, and that baby's not going to get any blood or oxygen. So then we got big trouble. Okay. So does everybody understand that? Okay. All right. Now, the active phase is anywhere from 4 to 8 centimeters. Excuse me, 4 to 8 centimeters, and typically on average lasts anywhere from 3 to 6 hours. Bless you. The duration here is 40 to 60 seconds, so the contractions lasting anywhere from 40 to 60 seconds, and the frequency is 2 to 3 minutes apart. Right. The contractions, the intensity is moderate to strong. I would go in there and check her now about every 30 minutes or so, just to make sure she's still okay, she's still hanging with me. Right. This is when, towards the end of this stage, is when if she's going to get an epidural, now's the time. Okay? If she's going to get an epidural, now's the time. There are epidurals called walking epidurals. Have you seen those or heard of those? Where it does not totally numb your legs. It just numbs down to the pelvis area. And so you can actually get up and walk around with an epidural. I think those are great because if you've got somebody who is totally numb, all the way down to their toenails, then they're not going to be able to help you push. Okay? They're not even going to be able to hold their legs in place in the stirrup. Okay? So that's very difficult when you're talking about those secondary forces or those secondary powers. If you are going to have help getting that baby out, because she's not going to have a clue. She can't even feel anything. Okay? So it does help to let the epidural only go so far so that they can move around. All right. Now, she's not so happy at this point. Okay? She's got a decreased ability to cope. She's doing okay, but she's not happy anymore. She's not Miss Molly Sunshine. All right. If you were the nurse and you had this person in this active phase, what would you want to make sure is going on in that room? What would you want to have?
Decreased stimulation.
Decreased stimulation. Would you want everybody from church coming to visit? No. This is not the moment, right? So I would put a sign on the door and say, please check with the nurse before you enter. I would have her relaxing and resting. Ask them, what sounds good to you right now? Do you want the lights dim? Do you want the TV on? Or do you want it on? What will help you focus and concentrate and relax? They have got to get some rest at this point because they got a lot of work ahead. So this is the moment we got to relax and rest, sleep. If you can get them to sleep through the active phase of labor, then the rest of it's going to be easy peasy. They may even wake up with frowning. I've had a lot of patients who wake up frowning. They've slept through the whole thing, which is wonderful. That's what you really want.
Do you give them medicine to go to sleep or not?
It depends on how anxious they are. They will give Ambien, especially if it's overnight, if it's during the middle of the night, and they're really wanting them to rest and relax. They'll give them an Ambien, and sometimes they'll wake up and they're just like babies, like getting ready to be born. It's nice. Okay. Transition phase. The transition phase is 8 to 10 centimeters. Okay. 20 to 40 minutes is the average time in this phase. No more than 1 to 3 hours. So 20 to 40 minutes is the average time. The duration of the contractions here are 60 to 90 seconds in length. The frequency is 1.5 to 2 minutes. And of course, the intensity at this point is strong. These are very strong contractions. Now you're assessing her more frequently because we're getting ready to go into the second stage. So now I would say about every 10 to 15 minutes you're in the room making sure she's okay, that the baby's okay, and that they're about ready to go. At this point, she has significant anxiety. Okay? Significant anxiety. Restless. They're irritable. This is where you see people saying, do not touch me, I hate you, you got me in this situation, do not come in this room. When I was in nursing school, I know y'all can't hear stories a lot of times, but when I was in nursing school, I had an Asian family that was delivering. This is at the Women's Hospital in Greensburg, and she made him stand in the corner with his nose in the corner. No lie. I felt so sorry for that man. Some of it, I think, was cultural, but he was, it was not in that corner. Now, at this time, they are going to start complaining of rectal pressure. Okay? They're going to start complaining of rectal pressure. What is that? The baby's coming down. That presenting part is pressing down on the perineum. Okay? Now, this triggers something. Okay? It's called the Ferguson reflex. Reflex, Ferguson reflex. And what it does does is when that presenting part hits the perineal floor, it triggers that reflex to say, okay, now I need to really open up, really need to stretch, really need to dilate, because we're getting ready to deliver this baby. That's called the Ferguson reflex. So, now that rectal pressure, they may have bowel movement. That was why back then, remember we looked at one of those 1940s things yesterday, and it was talking about taking casserole, putting them up and everything. That's the reason they did that, because they didn't want to poop during labor, okay? And if that happens, you just keep on moving. You just keep on going, right? And it's just, literally, it's just that there's enough pressure there. You don't even know it. You don't care at that point, honestly. You really don't care. Yes, that relief.
Good, like, honestly, that's a good parents. All that relief when the baby's out. Yeah.
Isn't it great? Okay. All right. Let's finish up these couple of stages and then we'll go on break. All right, the second stage. Okay, so that's all three phases of the first stage. The second stage is the delivery of the baby. Now, this stage may last anywhere from 15 minutes if they have delivered a baby before, and it may take up to 2 hours because we've got to get this baby out. This is the act of pushing. Okay, this is when we're pushing. So the second stage begins when the cervix can no longer be felt. So what does that tell me?
10, 100.
That we are at 10 and 100, right? That we are at 10 and 100. The cervix can no longer be felt. So now it's time for us to kick into gear. And we say, okay, we're going to push with every contraction. And that's what the coaches do. If you've been in the labor room, that's what their job is to do. If they don't have a coach or a family member in there, that's what the nurse does. They say, okay, especially if they have an epidural, because they may not feel when the contraction's happening. They may feel different, but they may not feel the contraction. So you're going to say, okay, it's getting ready to start, and you can tell the monitor when it's getting ready to start going up. And so when it starts, you say, okay, push, 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 and then relax, and then relax. Okay, so the evidence that we're in this station is that the baby is dropping down. Okay, so the baby, that Ferguson reflex was activated. So now we're going from 0 to +1 to +2, right? +3, right? Know what I'm talking about?
Mm-hmm.
Okay, so let's go down, 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 and then +4 is on the floor, right? +4, and then I'm going to put +4 is delivery. Right? These are strong contractions. There is not a D, I, or F for this other than the fact that they're just strong contractions. They are really pushing hard. Now you are assessing them and the baby frequently at this point. Every 5 to 10 minutes at this point, you're doing an assessment, making sure that. And this, I'm not talking about a cervical assessment necessarily. I'm talking about how's their blood pressure doing, how is their anxiety doing, do they need an ice chip in their mouth or whatever, how are they doing? And then how does the baby look on the monitor? Is the baby tolerating this? Are they doing okay? Okay. Now at this point, they have a sense of purpose. Okay. And a lot of women who are in the second stage of labor, they don't even hear you talking to them. They are so focused on the delivery of that baby. You can just be chatting away and tell them that they are not paying you any attention because they are focused. They know what I've got to do. It's like you give them that task, and they are so focused on doing that task, getting that baby out. They may still have some anxiety too. If you've got a young teenager Or even some, I've even seen some 20-year-olds I've seen some teenagers who do better than 20-year-olds. If you've got a patient who is extremely anxious, they can actually stop their labor progression. So you've got to keep them calm and you've got to keep them focused. Okay, that's your job. Focus and calm. This is going to end. You're going to get through it. The pain, coach them, talk them through this. Okay. The third stage of labor is the time after birth. Okay. It lasts from the delivery of the infant to the delivery of the placenta. Are they still having contractions? We hope. We want them to, because the contractions are what cause the villi. Did y'all talk about the little hair like chorionic villi? Yes. Okay. So on the surface, I don't know where my placenta is. Okay. On the surface of that placenta are those little hair-like, finger-like projections, right? And they stick right to the side of your uterus. We want those contractions. Okay, so here's our placenta. We want those contractions to, here it's stuck to me. We want those contractions to break those villi apart. It's like Velcro. Okay, we want it to break it apart and come off. So we have to have contractions during the third stage. Now, are they as strong as the delivery of the infant? No, but we still need to have them. The uterus still needs to be doing its thing. Once that placenta is done, we still need to have some contractions, because those contractions cause the blood vessels to contract, preventing us from what we said earlier, hemorrhaging. Okay. Still contracting. Okay. And you're still assessing them frequently. I'd say about every 15 minutes, making sure that that placenta is coming out. And at this point, they're relieved. I mean, it's over. It's done. The worst is over at that point. Now, let me tell you something. We're going to mention this one. We're going to mention this again, but I want everybody to hear this because this is one of Ms. Ward's biggest pet peeves. You should not see any physician pulling on that umbilical cord, speeding up that process. That is one of my biggest pet peeves. Now, they can guide it. There's a difference between laying it in your hand and gently just letting it, guide out. But if you see them yanking on that placenta, you advocate for your patient, because what can happen, and what happens is they get in a hurry, right? They may have 3 patients to deliver, and they're wanting to get to those rooms. So they're in a hurry. But what can happen, and this is, although it's rare, it can happen, if you pull excessive traction on that umbilical cord, it will turn the uterus inside out, and they will have to have an immediate hysterectomy, an immediate hysterectomy, and that is it. No more babies. Okay? And I don't think anybody wants to be responsible for that. Okay? So excessive traction on the cord is one cause of that uterus to it's called involution, okay? Or inversion. The uterus to invert itself. We don't want that.
How does that work with C-sections? Like with my third one, I went right in, no contractions, anything, and they did a C-section.
They manually break the villi. So they actually go in and just like manually taking the Velcro off. They just take their hand and break it apart. Yeah. Just special. Has anybody seen a C-section? Did you see that? Did you see them going in to reaching in to get the placenta out? And you may not have known what they were actually doing. And again, it's important too to get all those pieces of that placenta, right? We're going to talk about that later too, what can happen if we don't get all the placenta. Okay, everybody cool? Have you learned something so far? Okay, let's take breaks. We've got